Hello, and welcome again from my kitchen to chapter 6 of our ultrasound guided regional anaesthesia series. So today we're going to talk about the brachial plexus above the clavicle, which essentially means supraclavicular block and interscalene block. Now, these blocks are named when they were first performed based on the anatomy that you felt or detected or guessed at doing them. Now, there's no need for us to strictly follow the anatomical model of blocks now that we can kind of see the nerves that we're blocking. So it's frequently the case that, and it has been described in the literature, the so-called root of the neck block, which is basically a block between the supraclavicular and the interscalene, where the nerve bundle moves away from the artery, is encased by a sheath, and you can kind of catch all the nerves of the plexus in the root of the neck without risking, for example, a phrenic nerve block, or if you didn't want to kind of go supraclavicular for fear of not catching the ulnar nerve. So basically, we can block the brachial plexus above the clavicle wherever we see it. So initially, a bit of anatomy, just a reminder. So the muscle in this diagram is scalenus medius. Scalenus anterior has been removed, and the scalenus anterior sits anterior to both the brachial plexus and the subclavian artery, and it inserts about here on the first rib. Now, you can sometimes see the insertions of scalenus medius and scalenus anterior on the first rib, and it can catch you out because it sometimes looks like a hollow cystic structure, like a big vessel that shouldn't be there. So if you do think there's a big vessel there, one, put Doppler on, and two, follow it up to see if it turns into one of the scalene muscles. Again, more anatomy. So what this is illustrating is essentially the intimate relationship that all these structures have with the first rib. So here is scalenus anterior inserting into the first rib. Scalenus medius inserts into the first rib here. And you can see if the probe were placed across this direction, you can see how the brachial plexus sits a little bit lateral, a little bit superior, and a little bit posterior to the artery. So that's where you'd be looking for it in the ultrasound images. Now you can also see where pleura is. So pleura, you can see lateral to first rib, just where the pointer is now, is pleura. So you can see when we're doing a supraclavicular block, the four structures we should be able to identify are first rib, subclavian artery, brachial plexus, and pleura. Now we shouldn't proceed until we've identified all those structures, so we know exactly where we are. Again, this is the other side, so this is an anterior view of the right brachial plexus with the clavicle cut away. You can see scalenus anterior inserting into the rib, basically between the subclavian vein and subclavian artery. Brachial plexus coming out of the subclavian groove and then wrapping around the artery. Now what I wanted to show you from this diagram is how early and how tucked away the ulnar nerve is. And when we look at some of the anatomically the scans of the supraclavicular fossa, I'll demonstrate where we sort of need to aim for to maximise our chances of getting the ulnar nerve. Right, so here's the probe position for a right supraclavicular block. You'll notice that the probe is kind of parallel with the clavicle. It's pointing into the chest, and the only thing I'd sort of change about this setup is, one, the operator should have their hand on the patient, supporting it somewhere, and two, this exact position wouldn't leave a great deal of space to manipulate the needle. So what I'd rather do is have the patient sitting up a bit, have a pillow behind the neck, but moved over to the left side, so they're just on the edge of the pillow, giving you a bit of space to move behind. Or alternatively, you can get the patient sort of half rolled away from you if you're going to do it asleep. And that gives you a bit of space to kind of manipulate your needle lateral to the probe. Right, so here's a scan of what you should see when you stick the probe in the supraclavicular fossa. So the four structures we were looking for. So number one, the first rib. So that's first rib there. And you can see echo shadow behind it, except in the middle, and just in the middle of the first rib, down here, this is artifact. This is post-cystic enhancement from the subclavian artery. So this is the artifact that we talked about, sort of tricking you because you've got ultrasound beams bouncing to and fro from the inside of the artery, some of which then go out the top of the arterial surface, and it looks like there's a structure behind here, but that's echo shadow interrupted by artifact. So first rib, artery, pleura, lateral to the first rib, and brachial plexus around there. Blue dot is medial in this instance, so if we were going to perform this block, as I described previously, the needle would come in from the right hand side of the screen, and we only need to be, you can see that the brachial, the middle of the brachial plexus is about 1 centimetre deep. So if you're in 2 centimetres with your needle and you haven't seen it, then you need to take it out, start again, and get a better view of the needle. So we also talked about the ulnar nerve, and some sort of sources described getting the 8 ball in the corner pocket. Now that refers to this little angle round here, which is where the ulnar nerve comes off. So when doing the supraclavicular block, if you need to get, or it's important you block ulnar nerve territory, you need to get local anaesthetic right into that corner. So almost kind of lifting the artery off the first rib by kind of with local anaesthetic. Now, it's advisable to do that first, because if you, by blocking the deep structures first, you don't then potentially spoil the image of the superficial structures. So we'll just have a look at this clip now. So just, you can see both margins of the first rib. You can see the artery pulsing away there. You can see the brachial plexus lateral to the artery, a little bit superior or more superficial. So that's the four key things you need from a view of the supraclavicular fossa. You see the first rib, subclavian artery, pleura, and brachial plexus. Now the next image starts with the same anatomical view. So it's a right supraclavicular view. The blue dot is medial. You can see the first rib. Now, what I would do if I was performing an interscalene block is I would start with this image, because I know if I can identify those four things, I know where they are, and then I'd follow the brachial plexus into the interscalene groove. That way, you know exactly what you're looking at, you follow it into the interscalene groove, and if you do get lost or the anatomy gets distorted, you can just return back to that point and say, right, well, that's where I know what I can see, and then slide up the neck again. So what we'll do is we'll run this video, and then I'll point out the interscalene anatomy when we get to the top. So there's brachial plexus going from a sort of a bundle into a more vertical line, and the video stops in a second. So all we've done there is gone from the supraclavicular fossa and slid up into the neck. So here we can see the posterior border of sternomastoid, and then we've got scalenus anterior coming down here. Got scalenus medius here, and then the brachial plexus running all the way up there. So obviously, depending on how close you get to the neck, we're gonna see possibly some roots, possibly some trunks, possibly some cords in this view. So it may be, if you get a perfect view, you see the 3 trunks of brachial plexus. And if you, for shoulder surgery, you want to aim for the uppermost trunk, the sort of C5-6 trunk. But it's often the case that you get a partial view of that. Either you start seeing cords, or you start seeing, you know, some of the divisions after the trunks. So a safe approach would be to fill the whole interscalene groove with local anaesthetic. Now you can do that. Again, I would go in plane, and I would go lateral to medial. So in this instance, the needle would come in from the right-hand side of the screen, and you would see the whole needle into the groove, the tip of the needle into the groove, and then watch the local anaesthetic fill up the groove. Sometimes it's necessary to actually pop through the plexus to the other side of the groove. So you could initially sort of fill this side up, and then you can pop through where there isn't a nerve and fill the other side up as well with local anaesthetic. And again, studies have been done to demonstrate that that assists in getting a faster block, sort of a faster onset of block, and a slightly denser block, but not by much. So here's a picture. Now, this is the probe position I would have for the interscalene block, but I would go from lateral to medial rather than medial to lateral. But this is a perfectly reasonable approach to take. The other thing, I'll just run this video again, and once we kind of get to the top, the other thing we can do from this approach is perform a superficial cervical plexus block. So the superficial, the posterior border of sternomastoid is indicated there, as you've seen. Now, if you're able to get local anaesthetic into this space here, that would block the superficial cervical plexus. And it's another tissue plane block where you can dissect open the tissue plane with your local anaesthetic. So again, that's just a view of the needle position. I would go lateral to medial, and the same applies about either getting the patient sitting up with the pillow moved to the other side, or getting them rolled slightly away from you. Now, this slide just illustrates another technique. If you're a bit lost and you're doing the block with the patient awake, now I would personally do it with the patient awake. You can get the patient to just gently sniff in. Now, what this does is it activates the scalene muscles and really highlights the difference between the scalene muscles and the brachial plexus. So all we're doing here is just getting the patient to sniff in gently through their nose. So there, the scalene muscles activated and relaxing, and activated again. You can really sort of highlight the 3 nerve trunks. And just a quick another anatomical picture looking at the emergence of the superficial cervical plexus from behind sternomastoid.